Irrigation during implant placement to prevent bone from overheating. Handpiece for implant needs to be low speed and high torque. How do temperature of bone How to keep temperature of bone down when placing an implant? Use irrigation that has to be saline, alkaline saline. Percentage of implants successful rate after 10 years, 80% or higher. When not to load an implant immediately when you have placed a bone graft with guided tissue regeneration. What is the age to begin implant placement? 18 to 20 years old. After implant, connective tissue and epithelial attachment. After implant, the connective tissue and epithelial attachments are the same as normal tooth. The epithelium attachment is the same, but not the connective tissue. Epithelial attachment attaches to implant through hemidesmosomes. Maxillary and mandibular implant retained denture on anterior region. 4 for maxilla, 2 for mandible. After implant placement, an edentulous patient should avoid wearing anything for 2 weeks. Placing implant in maxillary central, most important thing to consider in aesthetics, the emergence. So emergence profile, creating an excellent emergence profile matters. The emergence profile should be considered as a whole concept. It is a portion of the prosthesis that allows the implant to turn into a natural looking tooth. It is the border between the surgical and prosthetic worlds. An excellent emergence profile gives a smooth transition from the circular implant platform to the natural shape of the tooth at the gingival level. It should be customized for every restoration. So the question says, placing implant in maxillary central, most important thing to consider in aesthetics will be the emergence profile. Next, extract upper posterior molars. What is the order of the extraction and why? The third molar first, then the second molar, then the first molar to prevent fracture of the tuberosity. Where is the maxillary third molar most likely to be displaced during extraction? Infratemporal fossa. What is the order of impaction of teeth? The mandibular third molar, then the maxillary third molar, then maxillary canines. Mandibular third molar, maxillary third molar, and then maxillary canines. Which is the least congenital missing tooth? The canines. Extraction for ortho treatment, maxillary first premolar. Impaction of maxillary tooth, which is the easiest to extract in a case with impaction of maxillary tooth? Distal angular. Wait. Mesial angular. Vertical So the difficulty index of removal of impacted mandibular third molars, as described by Pete Pedersen, mesioangular, easiest. Mandible impaction, the most difficult. Okay, so the most difficult in maxillar is the mesioangular. In mandibular, the distal angular. Impaction, oh, okay. Impaction of maxillary tooth. What is the easiest to extract? Yes, a distal angular or vertical. Distal angular. Direction to luxate, distal angular maxillary, third molar, distal buccal. Extraction of the third and second mandible, mandibular. What can you damage? The lingual nerve. Lingual nerve can be damaged when you're extracting a third or second. Nerve with highest risk of damage in vertical release flap. Lingual. Vertical release flap.
Nerve with highest risk damage in vertical release flap.
So, okay, so nerve with the highest risk damage in vertical release flap, lingual. Structure to watch during flap surgery, mental nerve. What goes through the V3? Which canal goes through the mandibular portion of the trigeminal nerve? Foraminal valley, V3. All patient medically compromised impacted third molars. What is only reason to do extraction if you notice pathology on X-ray? Most common complication of extraction, root fracture. Curettage, treatment of osteomyelitis after extraction, curettage walls of socket to remove infection. Extraction of number 30. Which direction do you use section? Vocal lingual. Direction to luxate maxillary teeth in children and adult. In children, you luxate palatally. In adults, buccal. Patient in radiation therapy or in bisphosphonate and needs extraction. What do? Root canal therapy, coronectomy, and seal. When IV bisphosphonates and extractions where what is needed, hyperbaric oxygen. Patient with Bjorn bisphosphonate related osteoradionecrosis of jaw. Bjorn bisphosphonate osteoradionecrosis of the jaw and bone is exposed. What is the treatment? Chlorhexidine rinse. SC, I guess, is scaling. Bronch, not Bjorn. Bronch. So, perioperative antibiotics in a chlorhexidine mouthwash has been suggested to reduce the risk of postoperative bisphosphonate-related osteonecrosis of the jaw, where invasive dental treatment is necessary. Okay, bronch. Bronch is bisphosphonate radio osteonecrosis of the jaw. Use of perioperative antibiotics in a chlorhexidine mouthwash. When to do serial extractions? When there is space deficiency in the maxillary and mandibular anterior regions. When to do serial extractions? When there is space deficiency in the maxillary and mandibular anterior regions. What is the number of the periosteal elevator? Number 9. Periosteal elevator, number 9. Number 9, periosteal elevator. Number 23 for lower molars is the mandibular cowhorn. Mandibular cowhorn is number 23. Number 74 is the ash forceps for mandibular premolars. Number 151 or 151A, premolars. One 51 and 151A. 65 bayonet for uppers or root tips, maxillary incisors or roots. Tri-elevator better used for mandibular molar roots. Best for single retained root or extract a mandibular molar. Upper cow horn is a number 88. Number 17, mandibular molar without fused root. Mandibular molar without fused root. Oh, I remember those. I used to use those. Number 17, for mandibular molars without uh, two roots. I mean, with fused root. Number 222 is for mandibular molars with fused tooth root. So, which is the tooth that is most likely to fracture during extraction? Maxillary first premolar. Maxillary first premolar is the tooth that is most likely to fracture during extraction. Medicaid covers one denture, extractions, and children under 18. Elevators act as what type of machine? A lever. Elevators used to advantage when interdental bone is used as fulcrum. Major reasons for loss of transplant. Major reasons for loss of transplanted autogenous molars. Traumatic occlusion. Major reason for loss of transplanted autogenous molars, traumatic occlusion, which is a tooth most likely to fracture during extraction, maxillary first premolar. Major reasons for loss of transplanted autogenous molars, traumatic occlusion. Primary purpose of compressing alveolar plates after extracting 4 plus adjacent teeth. Severe facial undercut. Severe facial undercut. Primary purpose of compressing alveolar bone plates after extracting 4 plus adjacent teeth. A nerve block of the max of a 5 of the second branch of the trigeminal B2 will be in the pterygopalatine space. Pterygopalatine space. Pterygopalatine space. Okay, next. Indurated asymptomatic swelling in mandibular premolar area. Altered vital. X-ray revealed discrete 41 millimeter radiolucency in the premolar area. What do? Mandibular premolar area. Altered vital. X-ray revealed discrete 41 millimeter radiolucency. Aspiration or needle biopsy. Inferior concha which bone?
Inferior concha which bone?
Turbinate.
Turbinate.
Primary symptom of intra-arterial midazolam injection, severe pain in extremity.
Primary symptom of intra-arterial midazolam injection.
Primary symptom of intra-arterial midazolam injection, severe pain in extremity.
Can tell ankylosed tooth if.
You can tell if a tooth is ankylosed by if it's submerged, a typical sharp sound on percussion.
Submerged atypical sharp sound on percussion different sound.
2 millimeter oral antral communication, you don't do anything. 2 to 6 millimeter, 8 antibiotics, nasal decongestion, and figure 8 suture. More than 3 millimeters, flap surgery. Caldwell look technique, removal of root tip from maxillary sinus incision over the canine fossa.